David Seaman, it's a very nice having you today with me and to allow us to discuss very important subject to two of us that really not just a chiropractic community or health community, but everyone else should be introduced to. And that's the chemistry of a movement that we will discuss today. So thank you for being here today and for giving us the opportunity to address that subject and to really go a little bit deeper so everyone else can benefit from the knowledge that you possess around that subject.
Okay, thanks for having me.
Mm-hmm. So tell me, David, as you allow me to address you by first name, which I really appreciate, tell me, do we know how much actually body mechanics affects body chemistry?
Well, the best way to look at it is that when you think about the body itself, it is made of chemistry.
Yes.
So if the body is made of chemistry, then anytime we move, we're actually moving our chemistry. So if you take for example, like a reflex hammer and you tap a tendon and you get the muscle contraction. Well,
yes.
By virtue of tapping the tendon, you create a chemical reaction in the sensory neuron called an action potential. It goes into the spinal cord and comes out with the motor neuron, you get a contraction. So just reflex testing, it's called a neurological reflex, but it's a chemical event induced by a loading event. And so when we think about the chemistry of movement, we first need to think, okay, so in order for me to sit here and think, okay, I'm going to stand up and move, I first have to think about it, which is chemistry. Then I create the movement itself and I'm moving my chemistry. And then when you're moving, the movement itself creates more chemistry. So the whole thing is chemical from beginning to end. And it doesn't change, for example, rehab work that one might do, all the fantastic Eastern Bloc, particularly the Czechoslovakians have done a lot of really great work in terms of rehab and manual therapy. Doesn't change any of that at all. Doesn't change stabilization exercises or proprioceptive training. It just changes how one conceptualizes what movement is so that if a patient or a client does not respond or an athlete does not respond, you may need to look chemically specifically in terms of dietary factors. Now that being said, even this, you'll like this. Years ago, I read this physical therapy, or sorry, it was exercise physiology book, and the author said, well, we did the double blind. Actually, was it single or double blind? Either way, the subjects were blinded.
Okay.
And there was, I think, 30 of them, and they did weight training for 3 months, and then at the end of the 3 months, those 15 subjects were selected, and the purpose was to work as hard as you could to win the biggest gains in strength and mass. And then the next phase would be taking anabolic steroids. Like the old days would be like Dianabol and Winstrol. I think Winstrol still used today. So everyone's working very, very hard to be as strong and fit and improve as much as they could during that 3-month pre-steroid phase. And then during the steroid phase, none of the 15 subjects got steroids. And it was a shorter period of time for training than it was to the buildup. And by taking a placebo, they actually had greater strength gains during the placebo shorter period than the pre-period, which means that this idea of a plateau, I think is physiological in many ways, but is psychological too. So the fact that you can placebo yourself into better outcomes, that's also chemical because stress is a stressful event, either acutely in the moment or chronically for a protracted period of time, increases the production of inflammatory chemistry. So when I think about plateaus for patients in pain, athletes who want to get stronger, more fit, and if they're not responding to all the mechanical work that one would do, or the musculoskeletal exercise, fitness, manual therapy, then you have to look towards what's going on between the ears and then what they're putting in their mouth.
I love that approach because everything is about what we put inside of our
body,
fueling us, right? Yeah. What physiological facts would you like to emphasize and you believe that need to be emphasized when we speak about the chemistry of movement?
Well, there are two different types of people. When you so your clients are mostly fit, probably, correct? And
correct.
I mean, in general. So yes. Someone who is fit compared to someone who has type 2 diabetes or metabolic syndrome. Now, metabolic syndrome, for those listening who aren't sure, metabolic syndrome is referred to the insulin resistance syndrome also. sort of a pre-diabetic state. So if you're talking about someone who is pre-diabetic or diabetic compared to someone who is not, their body structure is actually very different. And so when you start to think about loading, well, you always have to be careful as you load clients and patients to make sure you load them within their tolerance window. So someone who, for example, has type 2 diabetes, and if you do an electron microscope of a muscle biopsy, you compare that to a normal age-matched control subject who does not have diabetes, you will see with the electron microscope that mitochondria appear to be absent in the skeletal muscle of the diabetic patient. Well, there's probably 90% less, at least in the images that I have seen, compared to the non-diabetic. So for a diabetic patient, imagine this, because you understand what mitochondria are. They create the energy to move.
Absolutely.
And so they're substantially reduced in a type 2 diabetic or metabolic syndrome patient compared to a normal person. So when it comes to loading strategies, your pre-diabetic and your diabetic patients need to be viewed differently, because although our overall structures are the same in terms of, like, there's a bicep where it is and you have glutes and quads and everything else, they're actually functionally different at this point. Now that's a structural, but all structure is chemistry too, but there's actually there's a structural functional mutation or pathology that must be addressed.
And would that be the first step, David, to address from exactly the nutritional point of view, movement, both together? What would be that, ideal strategy to get that person to almost unmute that dysfunction that is taking place?
Yeah, I think that the also for, like, say, exercise professionals and trainers, they tend not to do laboratory work, blood work, or anything like that. But there is it's really interesting. There is one simple tape measure test that people can do that acts as a surrogate marker for body chemistry, and that's waist-hip ratio. Mm. So if you go to the airport or go to the mall, you see a lot of large waists that are typically larger than the hips. Mm-hmm. So for women, the waist-hip ratio should be normal, which means anti-inflammatory, unless you have an outlier, but anti-inflammatory would be less than 0.8. So for men, you want to be less than 0.95. If the woman is above 0.8 and the man is above 0.95 at any age, it doesn't make any difference. That means that they're walking into a low-grade inflammatory state to some degree, depending upon how long and how bad that waist-hip ratio is. So for people who have elevated waist-hip ratios, it actually correlates to cholesterol, triglycerides, glucose, hemoglobin A1C, C-reactive protein. So just by doing a waist-hip ratio, you can get an idea as to how flamed up, because my thing, as you can see from behind me, is about deflaming.
Yes. And
so my book is called The Deflame Diet, and the focus is eating to reduce inflammation, normalize all of those markers, but just using a tape measure can be used to identify where one is, and then clients and patients can basically check themselves at home. And as the waist-hip ratio improves, all of those chemical markers that I just mentioned can also be identified. So if someone has a bad waist-hip ratio, so it's elevated, mm-hmm. and they complain of aches and pains and malaise, fatigue, not necessarily depression where they can't get out of bed, but they just don't feel good. Yeah. So those people are much more flamey than somebody who has only a little bit of aches and pains. And so you have to load people according to how flamed up they are. And so if one wants to get a paper that I wrote that lists a bunch of the markers, not all the ones in my DeFlame book, but all you have to do is just Google BMI pain, and the first paper that will appear would be me. If you really want to be specific, you say BMI pain semen, SEAMAN, and then table 1 in that article lists all of these markers that can be tracked. And so if those markers are only a few out of place, well, that person could handle a more aggressive intervention. And no matter who you are, no matter how bad the diabetes is, right, you can still walk. So doing something is better than nothing. So I just wrote a new book on breast cancer, and I created some online courses recently. So I became more sedentary the first third of this year. Oh my God, time is flying. So I have to load less aggressively than I would have loaded, say, 6 months ago. So I'll modify my steps, my reps, and all that kind of stuff to make up for the fact that I have been quasi-sedentary. I mean, I probably gained about 10 pounds also. Now I probably have about 8 of it off, just because when you sit and you stress, you tend to just eat more. And if you eat more and you're sitting, you just tend to pack on weight, particularly like next year I hit 60. So the older you get.
Congrats.
Right. There is actually a term, it's called inflammaging. Inflammaging. So all of your young listeners should embrace their youth, because everybody inflammages. And as you inflammage, you tend to be less functional. Now, if you also pursue an unhealthy lifestyle, you accelerate the inflammaging and make it very pro-inflammatory inflammaging. And then that client or patient is even more difficult to deal with, because they've got multiple inflammatory problems working together, basically. And so.
Yeah, please go ahead.
No, please, go ahead. No, please. Sure.
No, it's just coming to my mind because, you know what, I, just like you, became more sedentary, used to work hands-on design programs for athletes, pre-post games and so forth, traveled a lot. And now as the CEO of the company, I sit a lot. I do research. I conduct interesting interview like with people of your caliber. I've learned more, but it consists of sitting. And me and my assistant even have a very great routine. We get up, we go for a walk, we move. I have a actually yoga mat in my office, and I move. We have a tendency to set up our clock for every hour. We get up and stretch for a few minutes, because it becomes very challenging to even concentrate and be effective throughout the day if you just sit and don't move, and you curl and you cave in, and everything is collapsed. Breath, the parasympathetic system, the relaxation is just, everything is compressed. And we really don't think about that, David, how it affects our.
Yeah, it's very interesting, actually. You mentioned the parasympathetic system, and so the opposite, well, that's your rest, your so-called rest and relax system, versus sympathetic is fight or flight. And there's a key nucleus in the medulla, which is about like right here above the spinal cord. And that key nucleus called the rostral-ventral lateral medulla. It's a certain area, and it gets a tonic input from another part of the hypothalamus. And this tonic input can pump up blood pressure. So movement helps to reduce the stimulation of that sympathetic center. And so not moving, even if you're not overweight, just not moving and stressing, you can become hypertense.
The one thing that I was trying to address, because we spoke about obesity, and in the article that I came across, you talked about tendinopathy and how researchers urge that, right, us to view it as the cardiovascular disease. Why is that?
Good question. And a lot of people have a hard time with that, because when you think about tendinopathy or a joint problem, everybody wants to just think in a mechanical sense, without including chemistry. So what researchers found is very interesting. So cardio, if I was to go, if I was 50 pounds heavier and I hadn't worked out in 5 years, and I'm pushing 60 and I go for a run, I have a heart attack, no one would blame the exercise for the heart attack. You would blame me for sitting on my butt for the last 5 years, gaining 50 pounds and smoking or whatever else I was doing terrible. Not that, I mean, that's not me, but if I did. So you wouldn't say the exercise caused the heart attack. You would say that the bad lifestyle, the pro-inflammatory lifestyle, caused my coronary arteries to develop atherosclerosis. And then I go and I exercise and I have a heart attack. So then the proper view would be normal loading in a normal cardiovascular event caused the heart attack because my anatomy was pathological and inflamed. Now, what they have found is that the atherosclerotic process, you know, well, I mean, that's the best word for it. It's an inflammatory event in our arterial system, and it also takes place in tendons. So when we think about heart disease, you know, arteries, you know, they're viewed as being clogging with cholesterol and fat and minerals. Well, the exact same thing happens in tendons and in articular cartilage in joints. The exact same. Where it's slightly different is because joints are different than tendons, because you have bone, you have articular cartilage. Tendons are, you don't have bone or articular cartilage. Tendons are these fibrous connective tissue, type 2 collagen. But the point, though, is that it's connective tissue. And so connective tissue is what our arteries are basically stabilized by. And so you see this connective tissue changes that are inflammatory in the cardiovascular system. The exact same changes take place in joints and in tendons. So if I was that same 50-pound overweight guy and I went out for a run, I didn't have a heart attack, but over time I developed tendon pain, the misinterpretation, or the exclusive interpretation in most cases, would be that I loaded my tendon and I developed tendon pathology because of loading. As opposed to viewing it as, who was the person who was doing the loading? It was a guy who hadn't worked out in 10 years and weighed 50 pounds more and had atherosclerosis chemistry degenerating the tendons, so the tendinopathy was there asymptomatically before I loaded. And so you don't blame the loading, you blame the tissue that was incapable of handling the proper load. And that's the way to look. And then that's not everybody. That's for, if someone who has a BMI that's perfect with waist to ratio and waist circumference, all is perfect, and they just go ballistic, well, they can get tendinopathy too, but that'll be due to aggressive loading rather than just a little jogging stuff. Jogging shouldn't give you tendinopathy or knee OA.
So let me ask you, David, would that be more like, you know, let's just take one of the athletic moves that creates a one way of consistent motion over and over and over, which is golf.
Right.
And it's just, you know, if you're a righty, you go right to left, right to left, right to left, from the, you know, your feet all the way from your hips, specific movement, specific rotation, right? Thoracic spine, you hope for that rotation to happen from the ground up.
Right.
How that motion is different, and the loading, the consistent loading, how that consistent loading can change our chemistry to create exactly chronic inflammation, and how one can prevent that. What would you advise?
The best way to look at that, well, first of all, you have to figure out who's doing this loading. Like when a lot of young guys and gals are playing, they play pain-free for a long time until they get older, and then all of a sudden, stuff starts to hurt a little bit. And you look at professional golfers. And I used to play golf and videotape golfers, and I don't watch much of it anymore. But what is still consistent is at the guy's age, they tend to gain weight. And so remember Phil Mickelson, when he first came out on tour, he was very lean, looked kind of like a model with his wife in Golf Magazine doing opposing stuff. And then Phil gained like, I don't know, 60 pounds.
Yes, he had a lot of pounds.
Yeah, and it wasn't muscle, obviously. It was adipose. And so when your adipose tissue mass grows in size, there's actually an immune profile in lean adipose tissue compared to obese adipose tissue. So the obese adipose tissue mass has an immune profile that's very similar, although lower grade, to that what you would see in a viral infection. And so with all this excess body fat, we're literally being infected with calories. So someone like that, when they are loading and aging, you end up with a state where, when you think about osteoarthritis and even tendon pathology, people refer to it as being a wear and tear condition. It's actually a wear and lack of repair condition.
I like that.
Yeah, that's the way it should be, because if you think about it, you would never have someone max out any exercise day after day after day, because you have to rest.
You have to recover.
And resting means recover, it means repair, right? Because exercise damages tissues subtly, and you have to repair. So if you are flamed up and are no longer able to repair effectively, Now, over time, we go through this wear and lack of repair state. And that is most of the biggest problem is for overweight people. Now, if you take Tiger Woods, for example, and you look at that, if you look at that guy's golf swing very, very carefully, these movements are so aggressive. And when you look at the lumbar spine, the joints in the lumbar spine line up this way. So there's not a lot of rotation taking place in the lumbar spine. You got to get up to the thoracolumbar junction where you get massive rotation taking place. And it appears like there's even greater rotation because you have shoulder movement on top of that. Right. But the amount of force generated and the shear force is generated in the lumbar spine over and over and over again. Now, Tiger Woods was, fantastically fit ever since he came on tour. And he's had many surgeries. He had that broken, I think it was tibia back when he won one of the events years ago before all of his problems developed personally. So here's a guy who didn't repair either, even though he was fit. So everybody has a certain loading tolerance that they must respect. You must respect your loading tolerance. Now, I have a rectus diastasis, which is a little small herniation in the linea alba. And I first came upon this when I was in high school doing sit-ups. I'm sure I'm shaking. I'm like, what is this little thing sticking out? And then I finally learned that it was a little subtle herniation in the linea alba. It hasn't changed at all since I was in high school, but that prevents me from loading the way I would otherwise if I didn't have that. So I have to take that into consideration and not try to keep up with some guy who might be built just like me, but has an intact linea alba, and therefore he will be able to load much better than I. So you have to take into consideration one's personal body type and pathoanatomy and movement dysfunctions, because some people have short legs, right, shorter feet, reduced motion from injury in one joint versus the other over time, and you have to be very careful to load according to that body and not some script. So that's why you do individual exercise prescriptions based upon I'm sure a really detailed Eastern European physical movement assessment. And so you do your prescriptions based upon the assessment outcome, not just because I want to have a big full turn and all this other stuff that these guys talk about. For a lot of people playing golf, they should just basically do a Mo Norman type swing where it's wider base, shorter backswing. And if you can't get the distance otherwise, but if that allows you to play longer and play with better wear and repair, well, then that's what you should do.
It's interesting, and I love that, I kind of brought up the sport that I'm familiar with, as my husband is a golfer. Now he is a instructor, and we have discussion about this a lot. And, there are sometimes aches and pains, and he works with different population, but majority is, mature population, baby boomers, and there are aches. And there is always like, oh, if you cannot do this, then just, turn your hip this way, or let's hold the club differently. And I, from a structural balance point of view, on the other hand, look at why it's not moving and how we can make it move, right? Because there are ways to make it, but just because you don't know how to, that doesn't mean you cannot address that and it cannot be changed. And I always look from the body, from the ground up. So the feet are such an important structure for me. And you as a doctor know the feet address how much proper movement we have in the hips and how then that we can or cannot load our back and how much rotation in the thoracic spine we get and so forth. And I think there is so little emphasis on this, Dave. And do you think it's a lack of emphasis because a lot of people don't know, or they just want to take the shortcuts?
I would say that as I've gone over the years, I would say that in my own experience, I find out all the time that even though I'm interested in topic A, when I go further in, I'm like, I didn't know that. So I think ignorance is a big thing, and then making assumptions. When I used to have a golf video, I used to have a system called Swing Solutions, and most people, when I videotaped their swing, you got it from front, behind, and then top down. And people who thought that they moved like beautifully, they're like, that's what I look like. So people aren't even aware of how bad their movements are, right? Yeah, and they think, well, you've seen it. People take a follow through and they're like falling, and then they just catch themselves, and then they plant themselves as if they had a good follow through. Yeah, so in general, people have a bad kinesthetic awareness. Now, your higher caliber athletes, of course, are very, 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 very different. And they're at risk too, just like Tiger Woods was at basically beating up his tissues, that he should have like rested more and allowed them to repair, and had been, I mean, why hit the ball 350 when 270 will do just as good without trashing your back? And so that's a really important message in terms of longevity for playing golf or tennis or anything else. I mean, if you're playing tennis, I mean, think about just throwing a baseball in general for a football, if you're a pitcher, and then you take a tennis racket. Now that lever arm becomes massively longer. Much more loading dynamics are taking place on the shoulder than if you're throwing, because it's the same move basically. So if you play tennis, you have to be very careful with overhand activities as you age. Well, actually all movements, just because as we age, we inflammage, and we are just not the same body that we were 20, 30, 40 years ago. But the most important thing for people to realize, and actually talking about joints, you've heard of omega-6 fatty acids, right?
Yes.
And all of your listeners, I'm sure, have as well. Well, you get omega, if you want to get a big dose of omega-6 fatty acids, the best way is to eat some potato chips or French fries.
They're loaded. Yeah,
because they're loaded with typically peanut oil or corn or cottonseed or sunflower, safflower oil. And so when newborn joints of all species studied thus far contain 0 omega-6 and omega-3 fatty acids, certainly 0 omega-6 fatty acids. Joints are actually referred to in the newborn as having an essential fatty acid deficiency. No omega-6, not needed. But as we age, we start pounding down potato chips and French fries. Over time, omega-6 fats that were never in our joints and are not supposed to be there start to accumulate in the articular cartilage.
Interesting.
And this happens before osteoarthritic changes are visible on X-ray, and so you have no idea you have osteoarthritis, but you have osteoarthritis chemistry before the osteoarthritis manifests itself. And this has been known, the earliest paper that I've read on this was from 1975.
Interesting.
Yeah. So all of our musculoskeletal tissues, muscles, joints, and tendons, they change their structure based upon the foods that we eat. So excess omega-6 fatty acids are going to concentrate in our joint tissues. As we go through this weight gain process, we're going to develop an atherosclerotic heart disease chemistry in our tendons, and we're going to lose mitochondria and skeletal muscle, and now go try to hit a golf ball.
Tell me, is there any correlation, David, between omega-6 and collagen production in the body?
I don't know if there is because when I look at, in my mind right now, I'm picturing collagen synthesis in my mind. Mm-hmm. And omega-6s are not involved. I will tell you that vitamin C is involved, sure. Magnesium is involved, some B vitamins are involved, manganese is involved. So it's mostly minerals, not fatty acids, because that's purely protein. And there might be, I'm not sure if there's any regulation by omega-6s. I do not think so.
Because recently I started to dig in, as you know, I'm interested and have been for several years right now in nitric oxide. And I came across a research which is starting to address that the more omega-6 we have, the lower nitric oxide levels in our body. And I didn't do enough of a diligent research to speak intelligently about that. Not yet, I will, but it was very interesting to me.
Well, that's separate though. That's different than collagen, right? Because yeah.
It takes us more into the, veins, arthritis, the arthrosclerosis, right. Yeah, per se, than anything else. And that kind of made sense to me. But I guess the question that I still need to answer is how much of it is too much, right? And what are almost the signs that one could identify it's starting to happen and that it's too much of omega-6? Do you know anything about it?
Well, you can do a blood spot test where you get we just lance your, just a little skin prick, and you put a little spot of your blood, and it's called, the company's called Brain Span.
Okay.
And then you send it in, and they give you your omega-6 to omega-3 ratio, a couple of other arachidonic acid levels tracked compared to where it should be. And then I think palmitoleic acid, which is reflective of a metabolic syndrome marker. So that's the best way. It's called the test was identified by a Dr. William Harris. It's called the Omega Index.
Okay.
And that way you can identify how, that's the best way. When it comes to nitric oxide, though, nitric oxide is produced in 3 places in the body. Maybe more, these are the 3 that I know. First, it's used as a neurotransmitter.
Mm-hmm.
And then it's also used as an inflammatory mediator for immune activity. And what you're referring to is vascular nitric oxide. Yeah. And so vascular nitric oxide, its functionality is improved if one has a bioflavonoid polyphenol rich diet. And so there are a couple of ways. So basically what you're talking about is being able to constrict and relax vessels based upon need. So nitric oxide is a big one. An easier one to conceptualize, though, is potassium. So when nitric oxide was first developed, it was and they found it in vessel walls. They called it endothelial-derived relaxing factor.
Mm-hmm.
So you got tightened and it relaxes. And some thought that potassium might have been that factor, and then they realized that it's not. So the name that they use for potassium is called endothelial-derived hyperpolarizing factor. And hyperpolarized means basically protracted relaxation. And so one of the most important factors in terms of exercise and blood flow is adequate potassium in the diet from green vegetables.
Absolutely.
So we get most of our potassium from green vegetables and animal protein. And what they found years ago is when they would exercise an animal on a treadmill and they made it potassium deficient, it went through ischemic changes, because when you contract a muscle, potassium should be released. And that released potassium causes the relaxation. So if you don't release potassium from muscle, you don't get the relaxation and you get ischemia. Hypoxia ischemia is called, worst case scenario, which you can do it in an animal, is called rhabdomyolysis, ischemic muscle damage. So potassium is really, really important. That's probably the best one for people to conceptualize, because the nitric oxide pathway is a little bit confusing, and people want to do sort of special expensive things when you can just eat a lot of, drink green tea, dark chocolate, berries, and vegetation, and that should be covered. And smoking knocks out nitric oxide in the vessel wall. So avoiding smoking and anything else that's pro-inflammatory.
You know, I appreciate it. When it comes to potassium, let's stick here just for a second. What, from a diet point of view and anti-inflammatory point of view, what potassium needs to be consumed with to increase the absorption? That's important.
You just eat it from food. Potassium is never supposed to be supplemented, because if you take a supplement of potassium, you can get a potassium spike and you can have a cardiovascular event from that. So potassium you should get your potassium from food. If you look at it historically, until the modern day, the average hunter-gatherer, if you want to use that word, before the industrialization and agricultural revolution, where our food patterns changed, the average human got about 7,000 to 11,000 milligrams of potassium per day.
Massive.
Yeah, and you had less than 1,000 milligrams of sodium per day. And now the average person has less than 2,000 milligrams of potassium and 3,000 to 4,000 to 5,000 milligrams of sodium. And that trashes vascular dynamics slowly over time until a potentially catastrophic event could happen.
No, I really appreciate that you addressed that, because, you know, there are companies that try to speak about electrolytes, but they forget about the potassium.
Oh, yes, amazing. Potassium is the one you're supposed to get the most of. And then really the other one that's forgotten is magnesium. And magnesium, I think, should be supplemented. And the average person probably would do well to do at least 400 milligrams per day. Potassium, magnesium is actually lost during stress. Mm-hmm. Magnesium deficiency, potassium deficiency, those two minerals are never really thought about, and they both correlate with slowly developing insulin resistance, metabolic syndrome, and diabetes. And everybody worries about calcium. Everybody worries. Now, the problem with calcium is that if you don't have vitamin K2, which we make from vitamin K1 that we get from green vegetables, you do not get proper deposition of calcium. So you'll start to get less calcium deposition in bone, and you'll have more calcium deposition in soft tissue, particularly the vessel walls. So green vegetables, really important.
Going back to that. David, one more question.
Yeah.
And I allow myself to quote you from the article. You said, we know that if fibroblasts are stretched, right? And we both know that they are during stretching, they release chemical mediators. And then you said the degree of which is related to the intensity of stretching, which we both know that's correct. Can you elaborate though on how fibroblasts regulate the inflammation and how can they promote the chronic inflammation?
Well, fibroblasts by themselves, that was just an example to demonstrate to the readers that we shouldn't view inflammatory, because I was talking about prostaglandin E2 release by fibroblasts. And prostaglandin E2 is the chemical that anti-inflammatory drugs like NSAIDs and Tylenol inhibit. And so there's a misconception in physical therapy, exercise physiology, chiropractic, and then orthopedics in medicine that only immune cells release inflammatory chemicals. All cells can, even for, and I didn't mention in that article, but if you and I were in the same location and we finished and say, hey, let's go out and get a cup of coffee, and you and I just ate 6 donuts each.
I don't know, I could do that.
I'm not saying, no, I'm just saying, but let's just say we did that, right? That'd be about, I don't know, that'll probably be close to 1,500 calories of pure sugar, flour, and fat. Yeah. So we would have this massive surge, this explosion of glucose in our system within 1 hour. And so insulin would be released as a consequence of that glucose level that was so high. Well, the other thing that happens when glucose levels rise that high, the cells in the pancreas called beta cells that produce insulin, they will release inflammatory chemistry like cytokines. And cytokines are typically released by immune cells. But even the beta cells of the pancreas that make insulin will release inflammatory chemicals if they're blasted with a high load of sugar. So all cells release inflammatory chemicals. Chondrocytes that make collagen for your articular cartilage, they release inflammatory chemistry. So the way to look at regulating inflammatory chemistry and healing is to get a normal waist-to ratio and make sure that all those markers in my DeFlam diet book or the BMI pain paper that I wrote are normal. And then that will allow for the normal homeostatic interaction between your fibroblasts, your immune cells, your chondrocytes, your red cells, your white cells, and the list goes on and on. So that's the best way to look at it rather than targeting one specific cell type.
Kind of cell.
Yeah.
Understood. If you could give one advice to a health professional, what would you invite them to change in their perception of the chemistry of movement?
Well, I think the best way to look at it is take out that tape measure. Everybody has a tape measure. Just, you pull it right out of the thing, it comes out and goes back in. Take that tape measure out and do waist-to ratio on every single patient or client. And if the waist-to ratio is elevated, be aware that that person may be more flamed up than the person who has normal waist-to ratio because of the correlation that occurs with inflammatory markers. And so you just need to be careful with people who have higher waist-to ratios. Now, that's not always the case. The kind of way you would know is someone who has elevated waist-to ratio is already playing golf and has no aches or pains at all, no problems at all. And if you were to do lab work on that person, even though they had elevated waist-to ratio, their markers might be okay, which means that they're tolerating. Because depending upon our genetic disposition or predisposition, we tolerate added body fat differently. And so the best way to identify someone who's not doing well is, well, if they can't walk briskly on the treadmill for 10 minutes, well, they're flamed up,
Sure.
And if they, and so you think about people going through like Sam's Club or IKEA, I mean, they're basically sleeping, on the aisles. When they go to the bed session, they're all falling asleep because they can't walk through the thing. So that person you should not want to load aggressively, and almost that always correlates to waist-up ratio. And so the best thing to do is, so you do waist-up ratio, and you ask that overweight individual. So say if they're 40 years of age, you ask them what they weighed when they were 20 years of age, 25. And if they weighed 30 pounds less, you ask them, how did you feel physically then compared to now? And if they say worse, well, you know, the flame is on. And so they say, okay, what we're going to do here is we're going to take this tape measure. You're going to go buy one, like from the dollar store. And we're going to get you down, if you're a guy, to below 0.95, and as a gal, below 0.80. And as people progressively move in that direction, they will start to feel younger and younger and younger. And if they're lucky, they might be able to feel like they were when they were in their mid-20s.
David, what do you say to the parents? Those parents who have those children. They almost, I have tears in my eyes when I think of this, because this is something that the kids are not aware of. They're predisposed already without even knowing for so much stress in their life and so much pain. How do we convey the message to parents who are setting up their kids for disaster?
Yeah, that's a really tough one, because no parent wants to look at themselves, and, well, human beings in general don't like to look in the mirror and think ill of themselves, right? So that becomes an issue in and of itself. And I'll tell you, just this week, or was it last week, eMedicine, by their Medscape emails, sent out an email blast, and one of us talked about how we need to start doing cholesterol testing and get 10-year-olds, 9 and 10-year-old children on statin medications.
Oh my.
So as opposed, so that describes the problem that we have with our system, as opposed to saying, you know, we in medicine have delivered a really bad healthcare message to rely on drugs and surgery, and now we're going to have 9-year-olds taking statins. So when I was 9, and I'm sure when you were 9, and you looked around the classroom, maybe 1 out of 100 kids were overweight, and all the teachers were normal weight. You look at baseball games in the States back in the 60s, 50s, and 40s, all the men wore suits and ties, and virtually not one was overweight. So we have become an obese, overweight. It's just, you know, society is decaying. And so one has to accept that and then do the exact same thing with their children. What they should do, a child does not get fat on its own, his or her own. It's in the house. And so what I see, I rarely see any lean parents walking around with obese kids. I see obese parents walking around with obese kids. And so it's the parents that have to get their own acts together and enforce that in the house. Get rid of all, I call it dietary crack: sugar, flour, refined oil. Tastes good, love it. I love sweet potato fries, love them. Shouldn't do it very often though, right? So I call that dietary crack, particularly if you're talking like, at least sweet potatoes are good. They start out okay, and you deep fry them and you screw them up. But if you're talking about a donut, that's sugar and flour cooked in oil. And so I call that dietary crack, because we taste it, and the second it goes down our throat, we want more. That's a withdrawal response. It's like a low-grade reward/addiction response. So I wrote a book, and it's only a 99-cent Kindle book. It's called Weight Loss Secrets You Need to Know. And this book goes through all of the physiological barriers to weight loss, the primordial barriers to weight loss, the psychological barriers to weight loss, the emotional barriers, and then dealing with the endless propaganda. I made it 99 cents so that there should be, I mean, that's basically 99 cents. You could get, you could buy 4 of those Kindle versions of the book for basically 1 latte at Starbucks. So people have to arm themselves with information, because we live in what is called, now it's actually called this by scientists, we live in what's called an obesogenic environment. Obesogenic. So if you or I are not wary of because if we're sitting at our desk working and we're just mindlessly eating, before we know it, we could be overweight and then obese. So we have to be mentally aware that we are living in an obesogenic environment, and then force your house to contain no dietary crack and unhealthy hypercaloric foods, all the packaged stuff. And it's really amazing. Whenever I shop, I look in the carts of people who are shopping, and who's ever overweight, I see very few vegetables. People are afraid of eggs, right? But they're not afraid of donuts. Watch out for meat, but man, those French fries and donuts, they're okay. So it really starts with the parents. And if the child is young, say 5 to 10, much more emotional because your limbic system is still cranking away and your brain doesn't really develop well into your mid-20s, the parents have to be strict and keep the crap out of the house.
Correct.
And the kid may have a temper tantrum because that's how they are these days, but in 5 days, broccoli will taste great. Brussels sprouts will taste great if you're starving.
And
So,
you have no other choice.
You have no other choice. And we didn't discuss this, but I'm pretty sure when you were growing up that your parents didn't have dessert every night.
Oh, I have this conversation with my assistant quite a lot. And I explained to her that when there was a dessert, it happened on Sunday only.
Right.
And the dessert was consistent of Jell-O with maybe David, some cream, whipped cream that was made.
Right.
Still kind of good fats and still Jell-O. It was all based on healthy gelatin stuff that I never got the sugar. A cake would come during a Christmas time or birthday.
See, that is historical eating, no matter where we would go on earth, any country, anywhere, that is historical eating. I remember, I was born in 1960, so what's for dessert? Nothing. I'm still hungry, eat more dinner. Children do not get that message these days, and the houses are filled with dietary crack. So.
And it's a valid point you've made. I always would have a soup for the first part of dinner, and dinner was at 3 o'clock, not at 7, 8 or so. And then it would be a second part of the dinner, which would be some kind of a starch. And you know what? Potato at that point, rice, it didn't matter. It was there. It was a small part of the plate. There was some kind of a protein source, and then vegetable. That's how I was taught. It was no other way for me. So soup, that filled me in. Then the source of good carbs, vegetable, protein. And then unfortunately, my parents didn't know any better. At that time, they would still put the, starch, but the simple, which later on I had to learn when I became an athlete. And I've made decision for myself, what I purchase, what I buy, what I put inside of myself. I eliminated that completely. And I don't crave it. I really don't, but I've made, educated now decisions that I have learned on my own mistakes, on my parents, lack of education back in the day. But they've done phenomenal job with what they knew and what was available to them. Phenomenal. And if we could put more attention on food, taking time to cook, not just buying prepared food, or if you are buying the prepared food, the takeout or the salads options, with other toppings that we have are there. They really are. There's tons of good kale salads, mixed greens, all of the other options, spinach or not, depending on how much you care about, valuable greens that you want to or like to eat. And if you are more prone for, some people say, well, I don't eat spinach because I have issues with the kidneys. Where is the spinach really the reason from your issues with the kidneys? I would argue that.
Probably not.
Probably not. But still people like to fight and, fight a reason why they shouldn't eat the greens, why they shouldn't eat the vegetables, why something comforting like pizza or French fries, it's the better way to go.
Yeah, it's really a problem. And so those people have to just look at themselves in the mirror and realize that they have an addiction-like issue and treat themselves like that. If someone's an alcoholic and they've been to whatever AA or whatever they went to, and now they're no longer, they're still an alcoholic, but they're not a practicing alcoholic. It would make no sense to go to a bar and read a book.
No.
Because you would be in the environment that is terrible for you. And that's why people need to keep their house basically clean, pure, and only go, if you want to go get ice cream, go get ice cream, and then eat it out. Don't bring any home, keep it at the house, because you end up with a spiraling event that occurs. You keep getting it, and the next thing you know, you can't stop yourself.
That's what we would do on a Sunday walk.
There you go. Yeah.
Sunday walk. It would be, let's go for a walk for an ice cream.
Right.
And you've made a very valid point. Don't bring the disease, or don't bring the temptation to your household.
Correct.
As much as possible. You have the power to control what you do for yourself and for your children, especially when we are speaking about parents, which is, the most important part to emphasize what's going on with our children.
Right.
I shouldn't say our, but our society.
I agree.
And
it's terrible.
I am all about supporting kids. I know that there is a hunger. And David, I think that we would both agree that it's the worst thing that can happen to a human body not to have any food, because that's a completely different issue. What decisions we make, how our bodies deprive from the right minerals, vitamins, and micronutrients. But that's different when you have the ability to make the choice. What do you buy? Make the right choice to fuel, not to destroy your body.
Right. And people think that they have to have a lot of money to eat well. You can eat really, really well with organic, even grass-fed meat at Aldi. I did a video called the DeFlam diet at Aldi's.
Did you?
Yeah, so that people can. Sorry?
Where can that video be found?
DeFlam Nutrition is my YouTube channel. So if they search, if your listeners just search DeFlam.com, just Google search, Google DeFlam.com, you'll come to my website, and then all that information is there. A link to my Facebook page and Twitter and YouTube is there also.
Great. So that's a one and a second and third social media sources that people can find more. What would you like to say as the closing, message to everyone that is listening? What's the most important key message you want to leave our listeners with?
Well, it's somewhat controversial only because of how the language has been manipulated. But I would say that the most important thing to do is to eat at a calorically appropriate level to maintain a healthy body weight for people as individuals. And for the average person, so I'm going to guess that you right now, you probably weigh now what you weighed when you were probably 20.
You're right. You're absolutely
right. Okay. I am the same way. I weigh now what I weighed when I was 20. So even when I had more muscle mass after a few of my injuries, I still weighed what I weigh now. So we should weigh. So women should weigh. Women typically achieve their proper adult weight, assuming no childhood obesity, between the age of 16 and 22, or really 16 and 20. Guys achieve their normal adult weight typically between 20 and 25. Some younger, but that's the average. So unless one was overweight then, that is what we should weigh now, unless there's a whole lot more muscle mass on the body. And so all one needs to do is think about how great they felt when they were 20 or younger, and that can be their life again. So it first starts with getting the calories appropriate so you can achieve a proper body weight and then maintain that. And then that can be done even without the healthiest of diets, but it's better to do it with a very, very anti-inflammatory diet because of all the wonderful benefits that we get from fruits and vegetables. So that'll be it. Calories really matter a lot.
Yeah, now if they come from a good carbs, vegetables, fruits,
right,
good fats or bad fats and bad sugars, there's a huge difference. Absolutely, I agree with you. I can't thank you enough. This has been fantastic, enjoyable, very informative for probably every single listener that has been with us. I would love to have the opportunity to maybe continue if there will be, questions and requests from listeners that they may have. And once this goes on the YouTube channel and our social media and our website, people may have questions. They may request a further discussion on it. And I would love that.
Absolutely.
I would absolutely love that. So for today, I am very grateful for your time, for your passion, and for your dedication to the field of health and wellness.
Thanks so much for having me.
Oh, you're so welcome, David. Thank you so much. Have a peaceful and joyful rest of your day.
You too.
Thank you.
Bye.